about the imaging of hindfoot and midfoot pain.
Hi, good evening, my professors, my colleagues, and our dear guests. It's my pleasure to participate today by giving this brief presentation about imaging of hind and midfoot. And actually, it's closely related to the previous lecture about Professor Bastawy. There are a lot of common subjects which are common between both lectures. I will start rapidly by saying that chronic foot pain is a common clinical complaint, often with significant impact on patient mobility, difficulty performing daily activities, and increased risk of falling. And despite careful clinical history and physical examination, providing an accurate diagnosis is often challenging because it has a broad spectrum of potential causes, therefore imaging play a key role in the diagnosis and management. Plain X-ray, of course, it will be the initial imaging of modality used for patients with chronic foot pain as in all musculoskeletal conditions. And MRI is increasingly used for problem solving in chronic foot pain to make precise diagnosis in equivocal cases when initial radiographs are inconclusive. MRI will provide excellent details about the soft tissue and OC structures, as we will see. I will start by saying that the foot can be subdivided into the hindfoot, midfoot, and forefoot. The forefoot comprises the metatarsals and the phalanges, and the midfoot starts from the metatarsal basis, comprising the cuboid, navicular, and three uniforms, and the hindfoot comprises the talus and calcaneus. And the major joints separating both regions are the tarso-metatarsal joint separating the midfoot and forefoot, and the mid-tarsal joint separating the hindfoot from the midfoot. Of course, we always start examination of patient foot pain by the plain X-ray of the foot with the standard radiographic views, plain X-ray posterior, anterior, and oblique and lateral views. Usually we proceed to the next step, which is the MRI, using different imaging protocols. Of course, it's different from to the other, but the needs to be done is two axial sequences, usually the T2 and the fat suppressed sequences, either proton density fat suppression or T2 fat suppression, and two coronal sequences, usually T1 and again fat suppression techniques, either proton, T2 or STEM, and at least to do one surgical sequence, at least to include surgical proton fat suppression, and the 3D sequence is helpful in evaluating the cartilage and other cartilaginous structures. The T1 weighted image provides good anatomic detail, and the T2 weighted images with fat suppression are useful to assess the osis or soft tissue edema, which are the hallmark in most pathologic conditions. It's important to say that the plate of imaging of the hindfoot are standard and identical to elsewhere in the body, the sagittal, axial, and coronal, while in the foot the sagittal images only are standard, but the coronal images and the axial images are perpendicular to elsewhere. I mean that the images that runs parallel to the long axis of the foot, which appear similar to the plain X-ray posterior anterior view, are the coronal images, while the images which are perpendicular to the long axis of the metatarsal, so that the metatarsal appear as the transverse cuts are referred to the axial cuts. Now I will go rapidly through the imaging appearance of some common hindfoot and midfoot disorders. I will start by one of the commonest is the Habermas syndrome, which refers to the triad of Habermas deformity, which refers to the prominent frontal-superior aspect of the calcaneus and insertional Achilles tendinitis, plus or minus tear, and retrocalcaneal bursitis. MRI, of course, will be excellent in delineation in the triad of this abnormality by demonstrating the deformity first and the insertional Achilles tendinitis, which is identified by thickening of the distal part of Achilles tendon, which is also nicely demonstrated on axial images by loss of normal anterior complete surface of the Achilles tendon and the retrocalcaneal bursitis, and associated subcortical marrow edema related to the calcaneal insertion of Achilles tendon. Plantar fascial disorders refers to disorders that present band of connective tissue that arise from the posterior aspect of the calcaneus and running along the plantar aspect of the foot to maintain the longitudinal arch of the foot. And normally on surgical and coronal pictures, it's characterized by being thin and uniformly hypointense and not exceeding 3 to 4 millimeter in thickness. In cases of plantar fasciitis, we find that there is uniform thickening of the plantar fascia, usually at its calcaneal insertion, with hyperintense thickening, which is best appreciated in fat-suppressed sequences, with or without associated bony spur. It's not calcaneal bony spur. It's not necessary to find a calcaneal bony spur, and reactive bone marrow edema at its calcaneal insertion and associated soft tissues. Plantar fascial tear or plantar fascial rupture also is, it's not that common, but it's a condition that we need from now and then, diagnosed by disruption and discontinuity of the fibers with edema or hemorrhage at the site of gap. Now we move to the painful accessory ossicles, and as we also as a previous lecture with from Dr. Mark, that we have a lot of accessory ossicles, of course, not all of them could be symptomatic. Many of them are asymptomatic, but sometimes because of instability of the synchondroses, which intervene between the accessory ossicle and the parent bone, sometimes this creates pathological findings and cause the patient symptom. We have the ostinabular syndrome, which is a pathological condition caused by the presence of an accessory navicular bone along the posterolateral aspect of the navicular bone, and it gives insertion to the tibialis posterior tendon, and repeated stress from the continuous traction of the tendon at this accessory ossicle results in the ostinabular syndrome, which is diagnosed on MRI by presence of edema either in the accessory ossicle alone, or it can cross to the adjacent parent navicular bone with or without disruption of the synchondroses, as we saw, and we saw a lot of cases at the previous lecture, either with maintenance of the hypointense stripe of the synchondroses or presence of edema of the synchondroses, meaning that there is ongoing disruption of the intervening synchondroses. The ostrigonal syndrome, in cases of posterior ankle impingement, will cause hindfoot pain by presence of these accessory ossicles and the posterior aspect of the talus, and the presence of edema at the accessory ossicle, and with more advanced stages there will be disruption of the synchondroses and crossing of the edema to the parent talus, and associated synovitis at the posterior aspect of the knee joint and the subtalar joint. Stress fractures in general in the foot, of course, are common in the metatarsals, but if we talk about the heart and midfoot, so stress fractures are common in the calcaneus and navicular bones. And of course, the initial stage of examination will be the plain X-ray, which can be entirely normal, but it's always typically third order third. But this time, a fracture line can be identified either a frank fracture line or subtle fracture line. So MRI will be always the next step if radiography is negative, and if there is high clinical suspicion of early injury. It has the advantage of demonstrating the bone marrow edema in the early stress reaction phase before fracture line developed, and after development of fracture line, also MRI will be able to identify the fracture line crossing the edema site. Now we move to the lateral hindfoot impingement, and I included it in this lecture because here we are talking about the lateral hindfoot impingement and not through ankle impingement, as Prof. Marker said. This is an extra-articular osseous impingement affecting the talus, calcaneus, and tibula on the lateral aspect of the hindfoot, resulting from hindfoot valgus malalignment and progressive lateral calcaneal subluxation, which leads to unusual and abnormal conflict along between the lateral process of talus and lateral aspect of calcaneus, and progressively with the distal end of the fibula, and it's usually associated with posterior tibial tendon insufficiency. And MRI gives characteristic appearance of this abnormality by presence of the edema at this characteristic location and the lateral aspect of the calcaneus and the distal end of the fibula, with progressive bony remodeling and flattening of these opposing bony surfaces at the contact site and neo-facet formation. Now we move to the tarsal coalition, which represents abnormal fusion between two or more tarsal bones. And in the foot, usually the coalition happens between the navicular bone and the calcaneus, calling calcaneonavicular coalition, or between the talus and the calcaneus at the level of the middle subtalar joints and the level of the subtentacular colli. This is the talocalcaneal coalition, and coalition can also be classified according to the type of breaching tissue between the two tarsal bones into fibrous, osseous, fibrous, cartilaginous, or osseous. I will start by the talocalcaneal coalition. Unfortunately, plain X-ray may be difficult to visualize the coalition site because of the oblique orientation of the tarsal bones and the complex orientation of the subtalar joint, but we depend on secondary radiographic signs to suggest the possibility of talocalcaneal coalition, such as narrowing of the posterior subtalar joint and related subchondral sclerosis, the presence of talar peak on the dorsal aspect of the talar head, and the complete C sign, and failure to visualize the middle subtalar joint on the lateral view. Talocalcaneal coalition would be nicely demonstrated by CT, either the bony type or the non-osseous type. And the coronal images are the best to detect the talocalcaneal coalition. And osseous coalition, we will see obviously the bony connection between both bones. This is the bony connection between the subtentacular villi of the calcaneus and the middle subtalar facet of the talus. And this is bilaterally, and by the way, talocalcaneal coalition is bilateral in about 50% of cases. And even in non-osseous type of coalition, CT findings are very suggestive of this pathology by the presence of these irregularity of the opposing articular surfaces at the middle subtalar joint and the related subchondral sclerosis. And there is another sign, which is the direction of orientation of the subtentacular villi. Normally, the subtentacular villi medially it slopes upward, but in cases of talocalcaneal coalition, it runs either in the horizontal plane or it slopes downward instead of sloping up. And of course, by MRI, in non-osseous type of talocalcaneal coalition, it will demonstrate the narrowing of the middle subtalar joint, the irregularity of the opposing articular surface, and the presence of subchondral edema along the articular surfaces of the middle subtalar joint. Now we move to the calcaneonavicular coalition, which can be detected on oblique anteroposterior radiograph of the foot, or we have a secondary sign on lateral radiograph, which is the elongation of the anterior process of the calcaneus, which we call the anteater sign. And then by MRI, there will be edema at this elongated anterior process, and we can see the sign of connection between the posterolateral aspect of the navicular and the elongated anterior process of calcaneus with bone marrow edema coming across, and the irregular bony interface at the interface of both bones. Sinus Tarsal syndrome was already discussed at the previous lecture, and we know that now that it's one of the theories that it comes from repeated lateral ankle sprain, and MRI characteristically demonstrate replacement of the normal fat in the sinus tarsi with either fluid or either scarring with ill definition of the interosseous fluids. The tarsal tunnel syndrome, this is totally different from the sinus tarsi syndrome, because sometimes some junior staff they confuse both entities, but the tarsal tunnel is totally different, because this is tarsal tunnel first is a fibrous tunnel that run postero-inferior to the medial malleus along the posteromedial aspect of the ankle and hindfoot, and it contains the medial ankle flexor tendons the posterior tibial nerve, artery, and vein, and the tarsal tunnel syndrome, and it's covered by the flexor retina. And the tarsal tunnel syndrome, this is a compressive neuropathy of the posterior tibial nerve at the tarsal tunnel, and patients typically present with pain paresthesia along and sensory loss along the plantar aspect of the foot. Tarsal tunnel syndrome could be idiopathic or could be attributed to a space occupying lesion within the tarsal tunnel, tumors, ganglia, accessory muscles, acquired or congenital foot deformity, and the aim of imaging is to assess whether there is a space occupying lesion causing the posterior nerve entrapment deformity. We should remember that I went through the most common causes of, the common causes of midfoot and hindfoot pain, but we have much more and more causes and much more and more anatomic variants which could be source of patient complaint. And I like to share with you two cases with unusual anatomic variants causing the patient's complaint. I will start by this 10-year-old girl which presented by chronic pain at the middle aspect of right hindfoot. And we found that there is abnormal configuration at the level of the middle subtalar joint. There is bone marrow edema. So we thought about tibio-calcaneal coalition, which is common, of course, at this age. But what was abnormal here that there was an accessory ossicle at the level of the interposed between the lateral, between the subtalar facet and the sustenmacular intellect. There was an unfused ossicle here, and it was nicely demonstrated here by the T1 and the coronal and the axial, and the referred physician insisted to do CT to better demonstrate and to confirm the presence of this ossicle, which is interposed between the sustentacular teli and the middle subtalar facet of middle subtalar joint. This is an accessory ossicle which is known, it's uncommon. This is known as os tentaculi with related tibio-calcaneal coalition. This was not single tibio-calcaneal coalition. So this is uncommon variant that could exist and we can meet it, and we should be aware of these innumerable variants which can explain the patient's complaint. The second case was a 42-year-old male presented by chronic midfoot pain. He did first plain X-ray, and when we look at the plain X-ray, we notice that there is an abnormal shape of the navicular bone. There is pointing of the lateral end of the navicular, comma-shaped navicular bone. And again, there is a separate bone structure which is interposed here between the navicular and the cuboid. And when the patient proceeded for further MRI, we found that there is advanced talonavicular and calcaneocuboid degenerative osteoarthrosis, this means mid-tarsal osteoarthrosis, and again there is an abnormal shape which is consistent with the abnormal shape seen by plain X-ray, and there is a separate bony ossicle here at lateral aspect of navicular bone. This is again an uncommon variant which is called the bipartite navicular bone. For me, I read from the literature that there are theories that this could be because the navicular bone developed from two separate ossification centers which failed to fuse. And Professor Mark Schweitzer at the previous lecture said that there is a traumatic theory in early infancy, whatever, that now we have the navicular is bipartite, it's two fragments instead of being one single fragment, and the instability between those fragments and continuous friction at the level of the mid-tarsal joints cause the mid-tarsal osteoarthrosis. So this is bipartite navicular bone with secondary mid-tarsal degenerative osteoarthrosis. So the take-home message that there are a variety of causes of hind and midfoot pain, including anatomic variants that may be the initial source of patient's complaint. It's important to remember that there may be other causes of foot pain which were beyond the scope of these lectures, such as osteomyelitis, rheumatological disorders, and musculoskeletal tumors, which will present the much different clinical picture. And also clinical examination is often useful. Imaging the foot is helpful to solve equivocal cases and pre-operative planning by showing the exact location and extent of the pathology. MRI of the ankle foot can usually provide a specific diagnosis, although its interpretation can be challenging due to complex regional anatomy and a wide range of traumatic and pathologic conditions. Thank you for your attention.
Thank you for your presentation. Excellent, elegant explanations. Any questions for Dr. Ali? Karim, I have a comment for you. That regarding for Mark about the ultrasound. I used to hear anything about ultrasound or robot ultrasound in babies or ankle pain or whatever. Is there still a role for ultrasound which is
of course
the area of right?
of course there is a role يعني فهو طبعا في الهاتش سندروم في التصوير الانترنت كان demonstrate suppression of synovitis لا هذا رول يعني هذا رول of course بس يمكن انا يعني I went for teaching purposes يعني for the illustrative images هو
So we have a patient with hand or hand pain or midday. Can start the ultrasound, then we can speak to MRI or we can jump to MRI.
The hindfoot and midfoot usually explain activity MRI, but the ultrasound يعني أنا for my experience for the ligaments for the tendon structure more, but for the osis abnormalities or the soft tissue abnormalities that I showed in my presentation, I think I went live for MRI.
Thank you.
I have to show you correct. Thank you for this last lecture, Dr. Ali. First of all, for any side pain, either posterior, medial, or lateral pain, we can start with ultrasound examination as a primary screening modality for the tendons and ligaments. Okay, as in Hageland syndrome, there may be Achilles here, Achilles bursitis, and even the spear in the calcaneal. As record the medial ankle tendons or lateral, ultrasound is very good. So we can start by ultrasound, and if there is negative results, we can proceed to the MRI. Okay.
Or the modalities they are complement to each other.
Yes, it is complementary. All the methods are complementary. Thank you.